Bismillahirrahmanirrahim. Quote of the day: a goal without a plan is just a wish. Today, I will present health system financing under kind supervision of Professor Dr. Saira Afzal. Learning outline of my presentation is introduction, models of health system financing, components of health system financing, financing agents, mode of financing in Pakistan, challenges, health financing for universal health coverage, recent advances, and at the end, there is an MCQ session. At the end of this presentation, the participants will be able to describe the health financing modes, challenges being faced by Pakistan, and how health financing contributes to universal health coverage. Health financing refers to the function of a health system concerned with the mobilization, accumulation, and allocation of money to cover the health needs of people individually, collectively in the health system. According to WHO, half of world's population do not have access to the healthcare they need. Over 930 million people spend at least 10% of their household income on healthcare. 75% national health policies, strategies, and plans are aimed at moving towards universal health coverage, and 100 million people are driven into poverty each year through out-of-pocket health spending. There are basically four models that are based on financing, and these models are Beveridge model, Bismarck model, National Health Insurance model, and out-of-pocket model. The first one is Beveridge model. Beveridge model basically financed by the government, funded by taxes. There are no out-of-pocket fees for patient or any cost sharing. Everyone who is a tax-paying citizen is guaranteed the same access to care. Potential risk of overutilization and rising cost and higher taxes. The Bismarck model is used as an insurance model, and it is financed by the employers, and employees are responsible for funding by the payroll deduction. Does not provide universal health coverage. It requires employment for health insurance, aging population, and the imbalance between retirees and employees. The next one is the National Health Insurance model. It is blend different aspects, both the Beveridge and Bismarck model. The government act as the single player for medical procedures, and providers are private. Universal insurance that doesn't make a profit or deny claims. The potential for long waiting list and delays in the treatment. And the last one is out-of-pocket model. The out-of-pocket model is the most common model in less developed areas. Patient must pay for their procedure out of pocket. The reality is that the wealthy get professional medical care and the poor don't, unless they can somehow produce enough money to pay for it. Healthcare is still driven by income. Now, the components of health system financing: revenue collection to raise the sufficient funds, pooling money to provide financial risk protection to the population, purchasing provision of services, efficient resources utilization, and buying best services. And what's the situation in Pakistan? In Pakistan, there are mainly two financing sources: public source and private source. In public source, general tax, local tax, earmark tax, and social insurance. And in private sector, private health insurance companies, employee health insurance, community self-help, and philanthropy. Institution or entities that channel the funds provided by financing source, for example, Ministry of Health, Ministry of Population Welfare, Ministry of Defense, Zakat, Pakistan Baitul Mal, NGOs, donors, and autonomous bodies like WAPDA or PIA. There are different modes of financing: out-of-pocket, tax-based revenue, official donor funds, philanthropic grants, social health insurance, social security, and community co-financing. What is out-of-pocket expenditure? Out-of-pocket expenditure as a share of current health expenditure for Pakistan was 56.2%. Principal mode of health financing and incurred on medicine and vaccines are most common. Tax-based revenue, main mode used by the government for the collection of revenue, and the low tax to GDP ratio is improved to almost 12.6%, and tax system is heavily reliant on indirect tax like goods. Official donor funds, there are different donor funds companies like WHO, UNICEF, Foreign Aid, and the 4.6% almost health sector allocation. The donor funding has been minimal, almost less than 2%. Philanthropic grants by different foundations, societies, individual, Pakistan, Baitul Mal, and Zakat. Almost 0.3 to 3% share of Zakat. Central Zakat Council, 60% Zakat spent on Guzara Alliance, like 500 per month given to the different families, poor families, and social assistance like food support programs, vocational training, and Tawana Pakistan. These are the different programs which are run by the Zakat system. Social health insurance, there are more affordable and equitable mode of health financing, and there are different type of program which are run by the social health insurance companies like Wasila Sehat Health Insurance Scheme 2012, Prime Minister Health Insurance Scheme 2015, in which 50,000 per families given, and government of KPK start the Sehat Insaf card in 2006, and now this card is also implemented in the Punjab, and now the government has renewed the policy of Sehat Insaf card, and now almost 70 and 30 ratio in the Sehat Insaf card, 70% paid by the government and 30% paid by the patient in current scenario. And SSP priority treatment, in which the chronic diseases, burns, RTA are involved, and in secondary care, maternity, and other emergencies, in which almost 60,000 per family is taken by the social health insurance companies. And in social security, there are type of social insurance. Employees, old age employees are benefited by the social security and worker welfare fund. It almost cover 5% of total population and 3.06% of workforce in formal sector pay and the pension scheme. And the SAS program is run by the social security. Now comes the private health insurance companies. Insurance Ordinance 2000, but benefits were less due to high costs and exclude groups with high risk diseases. Community co-financing. In community co-financing, there is cost sharing for countries who have predominantly rural-based, limited tax potential, and low coverage of social insurance, mainly provided by Benazir Income Support Program, Jubilee Life Insurance, Microfinance Institute, NGOs, and rural support programs. Challenges faced by the health financing in Pakistan. Issues with the health sector financing in Pakistan. There are mainly three issues: revenue generation, free pooling, and purchasing. Less revenue almost collected at national level. Tax collection system is insufficient. Innovative methods for tax collection are less used. Donor funding less than need, almost 2% of national health expenditure. At local level, less revenue is collected at district level because cost sharing method is not efficiently employed. Because there is low resources for health, low government spending on health, as relieved by Economic Survey of Pakistan, the country health expenditure total 1.2% of the gross domestic product in the outgoing financial year against 5% advocated by the WHO. Why is financing deficit? Generating funds to finance the deficit versus borrowing from public by the sale of bond and by printing new money. What's the solution of this less tax revenue, improve taxing, increase allocation to the health as pledged in Pakistan Vision 2025, almost 3% of GDP suggested 5% by the WHO in federal and provincial government. Now, what is pre-pooling? Health insurance is started but not universally covered. Large share of health expenditure is from out-of-pocket expenditure, around 70%. Catastrophic health expenditure, any expenditure for medical treatment that can pose as a threat towards a household, 40% or more. This is known as catastrophic health expenditure. Financially ability to maintain its subsistence needs, and its solution is expand insurance scheme to ensure universal health coverage. And the last challenge is purchasing. Issues with fund mobilization, underutilization, payment not linked to performance, more expenditure on salaries in secondary and tertiary care, leaving merely 15% for the preventive and primary health care. Outcome, insufficient and inequitable use of funds. And the solution is decentralization, accountability, coordination of stakeholders, strategic purchasing, spend more on health service delivery, preventive programs, capacity building of frontline healthcare workers, and governance. Flow of funds from federal to provincial government. Another challenge faced by government of Pakistan in terms of financing is the flow of the funds between different levels. So there must be a robust system for transfer of funds from the main collecting body to the designated provincial government. So there is a better distribution of funds at the grassroots level, like union councils or tehsils. Health financing in the aspect of universal health coverage. In universal health coverage, they say that there is affordability in the form of financial protection, in accessibility. Equity is the main component of universal health coverage, and the quality, acceptability in terms of quality, and availability in terms of good services. Universal health coverage means that all people have access to the health services they need when and where they need them without financial hardship. SDGs commits to achieving universal health coverage by 2030. At least 1 billion more people will need to have access to essential health services in each 5-year period between 2015 and 2030. There are 3 dimensions which are covered in the universal health coverage. It is coverage, access, and cost. Universal health coverage in Pakistan. To materialize the universal health coverage, central government and provincial government of KPK has started 2 social health protection schemes. Whatever 49 million people for all secondary health care. Beneficiaries are those living below poverty line. Limited inpatients in tertiary care is also covered. Premium for poor households, healthcare services provided by public-private hospitals. Now it's time for the recent advances. This is one of the article, impact of Pakistan Baitul Mal on the socio-economic condition of the beneficiaries. The target population of this research were the beneficiaries affiliated with the Pakistan Baitul Mal. After a careful analysis of data, it was relieved that most of them agreed that these services have positively impacted on their socio-economic condition. The top 3 influencing factors in this study include difficulty in application process, monthly household income, and employment status. This is another article. The title is Willingness to Pay for Community-Based Healthcare Insurance Scheme in Developing Countries, a Case of Lahore, Pakistan. Hence, awareness level of community regarding the benefits of is the major hindrance. The key policies priority is to increase the community awareness regarding the benefit of community-based healthcare insurance scheme and to increase willingness to pay rate among public. Factor influencing low enrollment in a community-based health insurance scheme, Karachi, a mixed method case study. The results show a large variation in performance of Debian for selected universal health coverage output. The result of the sensitivity analysis was also similar. Overall, Debian in Sindh province were better performing, and Debian in Balochistan province were the least performing. Access to healthcare, the responsiveness of health system, and patient satisfaction were found to be correlated with efficiency scores. Pakistan making a COVID budget in a struggling economy due to high debt to GDP ratio and the consistency deteriorating fiscal deficit. The government could only increase its expenditure for health and emergencies by a restricted amount. Most of these expenditures were financed by reducing the developmental expenditure, which may further dampen economic growth and increase unemployment. Cash disbursement programs such as SARS program may be effective in the short run, but the government needs to increase expenditure towards productive activities and build human capital to create job and decrease inequality. Additionally, there is a need to invest in social sectors such as health and education to reduce social inequalities that have worsened during the pandemic's conditions. Now it's time for the MCQs. Financial protection is measured by looking out of pocket payment in relation to which of the following: private spending on health, household living standard, total spending on health, total spending on education, and total spending on food.
B.
B is the right answer, household living standard. Mr. Abbas is the head of household. There are total 5 family members. Total earning of Mr. Abbas is 40,000 per month. Due to several health issues, his health costs exceed to 40% of household expenditure, a part of subsistence cost, which is called out-of-pocket catastrophic health expenditure, cost sharing, overutilization, tax-based revenue.
A.
B.
B is the right answer, catastrophic health expenditure, because almost 40% is given to the health. What is the most common cause of out-of-pocket payment that exceed a household capacity to pay? Outpatient medicine, dental care, inpatient care, treatment at private facilities, treatment at public facilities.
D.
A is the right answer, outpatient medicine. During the COVID-19 pandemic crisis, a country XYZ decided to cut down the taxes to add more to the health sector. This is possible by revenue generation, pre-pooling, purchasing, cost cutting, social security.
D.
A is the right answer, revenue generation. In most developing countries, the highest proportion of national health expenditures comes from purchasing, cost sharing, underutilization, out-of-pocket payment, or a private sector.
B.
D, out-of-pocket payment in developing countries. A country XYZ plans to improve the facilities available to their hospitals by giving more share of total funding to health sector. After the increase in the budget, the hospitals failed to improve their facilities despite having large number of healthcare workers. What could be the reason of failure? Overutilization, unequitable distribution, cost sharing, pre-pooling, or purchasing.
B.
B is the right answer, inequitable distribution. In a country XYZ, as per suggestion of the government, a new policy is formulated for the country's health sector financing, which is based on taxing and no out-of-pocket payment will be paid by the citizen. This is according to which of the following model of financing? Beverage model, Bismarck model, national health insurance model, the out-of-pocket model, or finance model.
C,
A is the right answer, the beverage model. It is basically a model which is run by the government and is paid by the citizen. Government decided to introduce a new scheme for old age and retired people based on the fundamentals of pay and pension so they can avail free facilities at the hospital. This come under which mode of financing? Social health insurance, philanthropic grants, private health insurance, social security. D is the right answer, social security. Under the heading of universal health coverage, the best method for protecting people from financial risk is increased tax, donor funding, prepayment pooling, cost sharing, overutilization.
C,
C is the right answer, prepayment pooling. The model, which is financed by the employers and employees, are responsible for funding by payroll deduction and it is run by the insurance companies. The model is beverage model, Bismarck, the national health insurance model, the out-of-pocket model, and the finance model.
C,
B is the right answer, the Bismarck model. This is the key of my MCQs YouTube link of this presentation, and thank you.